Hello friends, this is the last lecture of our calcium series. Now in this lecture we are going to discuss about the applied aspect of the vitamin D and calcitonin. Now what happens in vitamin D deficiency? So as far as the bone is concerned, the main effect of vitamin D is that it provides the calcium and phosphate to the bone. See, bone is made up of two structures. One is the organic component, another one is inorganic component that I already covered in our previous lecture. Now organic component is made up of collagen type 1 and inorganic component is made up of calcium and phosphate. So in vitamin D deficiency, though bone have a organic component collagen fiber, but they do not supply with the appropriate amount of inorganic component, that is calcium and phosphate. So basically there is a defect in mineralization of the bone. So they have a matrix, they have a extracellular matrix made up of collagen fiber, but they do not have sufficient amount of calcium and phosphate. So the main reason is that the main defect is failure to deliver adequate amount of calcium and phosphate. If that condition will happen in the children, it is known as a rickets, and if same condition will happen inside the adult, it is known as osteomalacia. Sometimes it is also known as adult rickets. Now let's discuss about the rickets. Now rickets is basically seen in children and result from calcium and phosphate deficiency. That deficiency will be by lack of the vitamin D. Now rickets, it tends to happen in the children who remain indoor most of the time and do not receive adequate vitamin D in the diet as well. So children who remain indoor and do not receive adequate quantities of the vitamin D in the diet. So that both the condition is happens in western countries because they have cold winter. The parents do not allow child to go outside and play outside, play outdoor. The children will remain indoor and do not even receive enough amount of vitamin D in the diet. This thing is not happens in most of the time in Indian culture. Now child who get adequate exposed to the sunlight, they do not develop rickets. Now what happens to the plasma level? As I told you, plasma calcium and phosphate will be decreased. Now how much amount of calcium, how much amount of phosphate will decrease, let's discuss it. Now as far as the calcium is concerned, the plasma calcium level is slightly decreased because whenever the plasma calcium decrease, it will leads to increased synthesis of parathyroid hormone, and increased parathyroid hormone will ultimately leads to increased bone resorption and prevent the calcium level from falling too much, right? Now what happens to the phosphate level? The phosphate level on the other hand, it will greatly decrease. Why? Because due to increase in the parathyroid hormone, as I told you earlier, whenever there is an increased parathyroid hormone, it will increase bone resorption. Now the parathyroid hormone, once it increase bone resorption, it will release calcium and phosphate both inside the circulation, but calcium will be reabsorbed and phosphate will be excreted. That's why phosphate will be excreted in the urine and it will greatly decrease the phosphate level. So increase osteoclastic activity, it will increase the release of calcium and phosphate both inside the extracellular fluid, but once they are filtered through kidney will reabsorb the calcium and it will allow phosphate to pass. So phosphate will be excreted in the urine. Now how you can identify the rickets? So let me tell you one thing. If you see a child suffering from rickets, you can easily identify how there are certain features, certain signs that you have to see. First thing, first thing is richitic rosary. Now what is richitic rosary? Richitic rosary is nothing but expansion. You see over here the violet dots, they are the expansion of the anterior rib at the costochondral junction. I am going to show you the picture in our next slide, so don't worry. So the meaning of richitic rosary is the expansion of the anterior rib and at the costochondral junction. Next sign is the Harrison sulcus. Now what is the Harrison sulcus? There is a horizontal groove that is shown over here. There is a horizontal groove will be seen at the level of insertion of the diaphragm, basically the costal margin. So Harrison sulcus, there is a groove that is present at the lower border of the thorax at the level of insertion of the diaphragm. Next one is the craniotabs. Craniotabs is nothing but a softening of a skull. And the next one is the pectus carinatum. Now this pectus carinatum is the bulging of this anterior aspect of the chest. That is the pectus carinatus, shown in the yellow box over here. Now let me show you certain pictures. See, this one is the, as I told you in our previous slide, this one is the craniotabs. What is craniotabs? It is the softening of a skull bone. Next one is the bowing of legs. You see, this picture is the person suffering from vitamin D and the same leg after exposure or after giving enough amount of vitamin D and calcium. So in rickets there is a bowing of legs like this. Now let me show you a picture of Rickety rosary. You see this prominent anterior aspect of the rib at the costochondral junction. This is the Rickety rosary. And next one is the expansion of the wrist joint. You see the wrist joint of a person suffering from rickets has a expanded wrist joint like this. Now how the rickets is treated? So the answer is that we have to provide enough amount of calcium and phosphate in the diet so they can easily incorporate and mineralization of the bone will happen. And also we have to give vitamin D, because vitamin D is basically responsible for delivering this calcium and phosphate to the bone. And the actual dose of the vitamin D is universal. It is 600 international unit from age 1 to 70-year-old age. And if the vitamin D is not given, as I told you earlier, the very little amount of calcium and phosphate is absorbed from the gut, and very little amount of calcium and phosphate is actually delivered to the bone to mineralize the organic component. Now the osteomalacia. Now what is osteomalacia? It is adult rickets. It is not developed routinely because adult is mostly exposed to sunlight routinely, so vitamin D level will be sufficient. Now once it happens, there is a deficiency of both vitamin D and calcium will occur. Basically the person who is suffering from steatorrhea. Now what is steatorrhea? Steatorrhea is the presence of excess amount of fat in the feces. So basically fat is not absorbed in GIT, so it is basically excreted in feces, right? Now why in steatorrhea there is a deficiency of both calcium and vitamin D will happens? The answer is like that. Vitamin D is actually the fat soluble. So to absorb vitamin D, fat must be absorbed. So if the fat get lost in the feces, vitamin D will follow. So vitamin D is not absorbed. And the thing that happens to the calcium is that whenever more amount of fat is present inside the lumen of GIT, the calcium will make insoluble soap with the fat and it eventually excreted in feces. So in steatorrhea both calcium and vitamin D will be lost. So in steatorrhea both vitamin D and calcium will be passed in the urine. Now let's discuss about the vitamin D resistant rickets. Sometimes when you provide enough amount of vitamin D, then yet person do not recover from the rickets. So there are two type of the vitamin D resistant rickets, type 1 and type 2 vitamin D resistant rickets. Now what happens in type 2? In type 1, the type 1 patient do not respond to the vitamin D. Now in this case vitamin D is about 25 hydroxylase calcidiol. We are talking about calcidiol, right? But the person is response to calcitriol. So but a normal response to 125 dihydroxycalciferol. So in type 1 the problem is that person is not response to calcidiol but it responds to the calcitriol. So the problem will lies in the conversion of calcidiol to calcitriol, that is at the level of renal the enzyme 1-alpha hydroxylase is defective. Got it? Now on the type 2 vitamin D deficiency, vitamin D resistant rickets, person do not respond to calcidiol as far as calcitriol. Got it? And the problem in type 2 will lies at the receptor level. The person does not have a active receptor to respond calcitriol or active form of vitamin D. This is the difference between type 1 and type 2. So in type 1 the defect lies on the enzyme, and in type 2 the defect lies on the receptor. Let me repeat one more time. Type 1 has a problem in 1-alpha hydroxylase enzyme, and type 2 has a problem in receptor of the active form of vitamin D, that is 1,25 dihydroxycholecalciferol. This is all about the vitamin D. Let's discuss about the next and last hormone, calcitonin. Now as far as the calcitonin is concerned, it is basically situated over the thyroid gland. It is secreted by parafollicular C cell of the thyroid gland. It will be seen in between the follicles of the thyroid. See this red color, these are the parafollicular C cell. This one is the parafollicular C cell, and this one is the follicle that is actually secrete the thyroid hormone. We discussed this thing in our thyroid hormone lecture. Now as far as the calcitonin is concerned, it is the peptide hormone. So it has an amino acid sequence. It has a 32 amino acid sequence, and the effect of the calcitonin is exactly opposite to the parathyroid hormone. It lower the serum calcium level. So whenever there is increased plasma calcium, there is increased calcitonin secretion. So there is directly proportional to the plasma calcium and calcitonin. So more calcium inside the circulation, more calcitonin is secreted. On the other hand, parathyroid hormone has an inverse relationship with the calcium. Whenever more calcium inside the circulation, less parathyroid hormone secreted. Now how the calcitonin decrease the plasma calcium level, the mechanism of action. Now this calcitonin will act on two organs, one is bone, another one is kidney. Now what it will do to the bone? See, the beauty of the calcitonin is that its receptor is actually present over the osteoclast. On the other hand, vitamin D and parathyroid hormone, both the receptor are present over osteoblast. Alright, what calcitonin will do? Calcitonin ultimately inhibit the osteoclast function and decrease bone resorption. This is the first effect. And the next effect and most prolonged effect of calcitonin is that it decreases the formation of new osteoclast. Got it? So first they inhibit already present osteoclast, and the second effect, it prevent formation of new osteoclast. Got it? This is the effect on bone. Now effect on kidney. In kidney it will increase the calcium excretion in the urine. So parathyroid hormone will increase reabsorption of the calcium, while on the other hand this calcitonin will increase calcium excretion in the urine. Now let's talk about the negative feedback control of the parathyroid hormone and calcitonin. This is the beautiful diagram, this is the flow chart. So whenever there is decreased plasma calcium, hypocalcemia, it will stimulate the parathyroid gland, it will inhibit the C cell. So ultimately it increase the parathyroid hormone level and decrease calcitonin. So ultimately there is increased plasma calcium. On the other hand, whenever there is increased plasma calcium level, it will stimulate the C cell and inhibit the parathyroid gland. So ultimately it decrease the parathyroid hormone secretion. On the other hand, it will increase calcitonin and decrease plasma calcium level. Alright. Now let's talk about the regulation of the calcium via if you keep in mind this picture of what happened when there is a decreased plasma calcium, what happened when there is increased plasma calcium. Got it? So whenever there is a high plasma calcium level inside the circulation, it will ultimately increase calcitonin secretion, and this calcitonin will inhibit the osteoclast function and decrease calcium level. Once the calcium level is low, this low level of calcium will stimulate the parathyroid gland, increase the parathyroid hormone secretion, and the parathyroid hormone ultimately going to increase bone resorption and increase the calcium level directly, and by stimulating the calcitriol, it increase the absorption of the calcium. This is all about the regulation of the plasma calcium. Now how to write it down in the exam? The answer is like that. How to write it down, the regulation of the calcium? So whenever there is increased calcium, that increased calcium will stimulate the parafollicular C cell. It will increase the release of calcitonin, and once the calcitonin is raised, it will inhibit the osteoclast. So ultimately it will lead to decreased blood calcium level. So whenever there is a decreased blood calcium level, it will stimulate the parathyroid gland, and once the parathyroid gland it will secrete as stimulated, it will secrete parathyroid hormone, and it will increase the calcium release from the bone, and the other action, it will increase the formation of vitamin D, and this vitamin D it will ultimately increase calcium reabsorption in the GIT, and parathyroid hormone it will increase calcium reabsorption from kidney. So ultimately that will lead to increased calcium level. This is how the calcium regulation will be written down. Now here's the thing, two similarly sound but totally different term that is frequently used in calcium, that one is the osteopetrosis and osteoporosis. Now what is osteopetrosis and what is osteoporosis? Let's discuss that thing. Now osteopetrosis is basically the defect in osteoclast. So once there is a defect in osteoclast, there is decreased osteoclastic activity, but osteoblastic activity remains normal. So basically unopposed osteoblastic activity. Let me write it down for you guys. So in osteopetrosis there is osteoclast are defective, so there is decreased osteoclastic activity of the bone, while on the other hand osteoblast will operate unopposed. So what will be the reason? It will leads to increased bone density. Once the bone density will increase, it will narrow down the foramina, so basically neurological deformities will happen, and it will also decrease the bone marrow, the space for bone marrow, so hematological abnormalities will also be seen, right? So in osteopetrosis there is defect in osteoclast. Now what will happen in osteoporosis? Osteoporosis is exactly the opposite. There is excessive function of the osteoclast, so there is a loss of bone matrix in this osteoporosis, and it increase incidence of the fracture. The most common fracture that is seen in this osteoporosis is Colles fracture. It is the distal forearm, common in distal forearm and vertebral bodies and hip. Alright. So what is osteopetrosis? There is a defect in osteoclastic function, and what is osteoporosis? There is a excessive osteoclastic activity. Now what are the causes of the osteoporosis? Osteoporosis are basically happens when there is a lack of physical stress on the bone, and the malnutrition, and the lack of the vitamin C. So vitamin C is responsible for mainly the formation of the organic component of the bone, that is collagen fiber. Then the Cushing's syndrome, we are going to learn in very detail in Cushing's syndrome in steroid hormone. And the last one is post-menopausal lack of estrogen secretion. So whenever there is a less amount of estrogen secreted in woman post-menopausally, it will causes osteoporosis. So you might be thinking, what is the role of estrogen on inside in bone, right? What estrogen do to the bone? Now the estrogen will inhibit the secretion of certain cytokines. That cytokines are interleukin 1, interleukin 6 and TNF alpha, that is tumor necrosis factor alpha. All these three cytokines will ultimately increase the development of osteoclast. So estrogen, by inhibiting formation of this inhibiting the secretion of these cytokines, it ultimately decreases the development of osteoclast. Alright. Now next thing that estrogen will do, it will stimulate the production of transforming growth factor beta. Now what this transforming growth factor beta will do, it will increase the apoptosis of the osteoclast. So actually what estrogen will do, estrogen will inhibit the cytokines that will increase the formation of osteoclast. So estrogen will decrease the formation of osteoclast, and again estrogen will do apoptosis of the osteoclast, so it will destroy already present osteoclast, so there are less chances of more osteoclastic activity and osteoporosis. Now the treatment of the osteoporosis, how the person will be treated who suffer from osteoporosis. The first thing is the estrogen replacement therapy. It will mainly help in the bone density. Now but here's the catch, once you give more estrogen to the subject or the patient, there are more chances of uterine and breast cancer. So you are trying to cure osteoporosis, but you are actually giving to the cancer to the subject. So to prevent such kind of side effect of the estrogen, there is a one more line of drug that is will be made, that is known as selective estrogen receptor modulator, SERM. Let me write it down, selective estrogen receptor modulator. Now the beauty of that drug is that this drug has a capacity to maintain bone density, but they do not increase incidence of the uterine breast receptor via acting on different receptor. Alright, that we discuss in detail in our steroid hormone lecture. Now the name of the drug, let me give you one name, that is the raloxifene. The drug name is raloxifene. And the third one is the bisphosphonate. Now the bisphosphonate are basically inhibit the osteoclast, so it inhibit the bone breakdown and preserve bone mass and ultimately decrease the risk of the fracture. And the final and most effective one are the physical therapy, so do exercise. Right, this is all about our calcium lecture. Thank you. Next time when we meet, we are discussing about the pancreas. Thank you.